Invite Dr. Ken Fong to begin the show. I will talking on subthreshold micropulse laser, the need, rationale, and principles. Dr. Ken Fong.
Thank you, everyone. Thank you, Anand, for the kind invitation. And I'm just going to share my screen. Just give me a second. Okay, so my presentation is up. I'm going to switch to presentation mode. Okay, so basically, I'm just going to give a quick introduction to the role of subthreshold laser. I've presented on this many times in the past. I apologize if some of the slides are repetitive, but I think it's as what Victor has mentioned, it bears repeating because this is a very unique modality of treatment for our patients who have macular diseases. And I think as we will see from the other presentations to follow, it will become more relevant in the years to come for several reasons. So these are my financial disclosures. I've a consultant for Quantel Medical for many years and helped develop their subthreshold laser system together with many other doctors. Together with Victor, Lite, Jay, Alejandro from Spain, we were the original co-founders of the Subthreshold Laser Society, and I'm very pleased that Anand has agreed to take on the challenge of leading, being a committee member with us, and this is his. I thank him for organizing this important webinar. So why do we still need laser for macular diseases? First and foremost, I think we can see that many countries, India included, Malaysia included, even US, UK, Australia, they cannot afford continuous unending intravitreal injections. And we have hundreds of webinars about fixed PRN, treat and extend, which anti-VEGF to use, how often, and so on and so forth. And now we have companies talking about doubling the dosage of the anti-VEGF or longer acting agent and so on and so forth. But it becomes a huge burden to our health economy. And cases of diabetes are increasing worldwide. We see that everywhere, DME. And interestingly, CSR cases are also on the rise, as well as proliferative diabetic retinopathy. There are many cases we all have come across that are unresponsive to injections, whether it's anti-VEGF or steroids. And we often wonder whether if we had treated them initially with laser, could they have had a better result? So what do we really mean by subthreshold? I think this is the crux of the argument that we have all over the world. Everywhere I go, I have doctors asking me, what do you mean when you do this and so forth? And even before the webinar, we had quite a good discussion among ourselves about our different parameters. And Jay will follow up with a recently published guidelines endorsed by the society that we feel will be good as a baseline to follow. So subthreshold laser really means you cannot see any visible changes during the laser procedure. And if you use fluorescein angiography, OCTA, autofluorescence, you can't really see any changes. You have certain software like the endpoint management with the Pascal TopCon, whereby you can see a visible scar at the beginning and the end of the laser burn. There's also technology by Alex where they use 2RT, very high power, but very short nanosecond durations. But what I'm referring to is really the pulsing technology that Victor has mentioned has been around for almost 20 years. Initially introduced by Iridex, and they called it, it's been trademarked as Micropulse. But other companies such as Quantel, ODOS, and Lumenis also have similar pulsing technology called by different names. So we use the word subthreshold to encompass all these different modalities. And as a whole, the society believes that they're all pretty much the same, no matter what one company says or the other. We feel that pretty much it's a similar sort of technology whereby they chop up the laser beam. What are the main issues with subthreshold laser? Number one, all the published studies use different parameters. They might use 5% duty cycle, they may use 10%, they may use 15% duty cycle. Some use a fixed burn power, some use titration of the power. And there's a high risk of undertreatment. If you are starting up, you're often very scared of increasing the titration of laser power to cause a scar. Very often, as we see, laser is often used as a last resort after failure with anti-VEGF or steroids. There are no published studies comparing subthreshold laser versus anti-VEGF. However, I believe the Diamond study has the initial results of the Diamond studies has been reported at a recent Macular Society meeting, and we look forward to further details on that, whereby subthreshold laser was used together with anti-VEGF for DME. So how does subthreshold laser works? It works by changing the microenvironment through stimulation of RPE cells. So if you see here, if you do a traditional full fluence laser, you kill the RPE cells, you have a dead zone and a sublethal zone. And the dead zone is where you see the initial white burn, and the sublethal zone is where the burn will extend to over time as a scar. You really don't need to kill any RPE cells, but you need to elicit enough energy to get a response on RPE cells to increase the production of matrix metalloproteinase inhibitors. And these, we believe, is the biological effect that helps improve the functioning of the RPE cells and reduction of edema. So this is the current treatment parameter I use. I believe Jay will go that further on that, but I use the OCT guided thickness map at 5% duty cycle. I do titrate. Basically, I do a visible burn outside the macular area, and then I reduce the power by 50%. I use a 160 micron spot size with a dense pattern and treat the thickened areas that I see on OCT and evaluate at 12 weeks with OCT. You can or cannot use you may or may not want autofluorescence. It's not really necessary. And how is it done? You choose, we have the pattern scanning option on our laser machine. So we choose a variety of patterns. So here you can see on the left, area of thickening on the OCT. I have it printed out when I'm doing the laser on a patient in the room. But I think some of the companies have now, you can actually overlay the OCT on when you're doing the laser machine, and a lot of more options now. And then you remember where it's the thickening as you do a normal focal laser. You mark the area, and then you titrate the power, and then you go ahead and then choose reduce the power by 50% and treat the area. So it's suitable for many types of DME. Clinical significant extrafoveal is perfect. Fovea involving. I often do it in combination, whereby I inject anti-VEGF first to reduce the thickening, and then top it up with some laser over the residual areas of thickening. Here are some useful cases that Dr. Alejandro Rios from Spain has published upon. I think it's very useful to share. Here's a case of extrafoveal edema. At 1 month after subthreshold laser, you see a reduction in the thickness, and at 3 months, there's further reduction with no need for any anti-VEGF treatment. Here's a clinically significant juxtafoveal edema, 1 month after treatment, a good response, and 3 months after treatment, further reduction with no need for any anti-VEGF treatment. So you can see a color picture side by side. There is a reduction of the exudates, but it's probably some worsening of the overall diabetic retinopathy. This is for more advanced users. In cases where you have fovea involving good vision, the patient had some anti-VEGF treatment given, and then a top-up with laser around the residual thickening areas. Here's a case of laser after intravitreal injection. So you can see here there's some more edema, infranasal, and top-up laser was done at 3 months. CSR is also a very common topic that we are seeing, and I think we'll have some cases presented on that. So I think Dr. Lee Tae-woo is here, and he'll be able to share further on the PACORE study that he and his team has published on. One common discussion is about the PLAY study, which was conducted in Europe, where they showed that PDT was superior to subthreshold micropulse 810 nanometer laser. But our argument is that the wavelength chosen is not something that we would recommend. Most places are using the 532 or 577 nanometer laser, and we believe the wavelength is important. And the PACORE study showed that that was actually better than half dose PDT for CSR. So I won't go to this. I think Lee Tae will present it. But what it showed really, subthreshold laser group had a much larger percentage of more than 3-line gain from baseline compared to the half dose PDT group. Here's a case whereby you have an acute CSR of less than 1 month duration, and you just treat the hotspot with a subthreshold laser using the same parameters as DME, and there's a good resolution. Here's a case from Victor many years ago, a patient of chronic CSR. You can see the hypoautofluorescence on AF and the chronic thickening here. Multiple hotspots showing diffuse leakage. Subthreshold was applied all over the leaking areas. and using the same protocol, and there was a reduction in the fluid, but the vision did not improve much due to the chronicity of the leak. So I would encourage all of you to check out our website, solslasersociety.com. We have many international members, and we are developing protocols for the different machines and running clinical trials for multiple conditions. So in summary, it works. All of us are here today. I think all the case presenters will have good experience to share what their experience with subthreshold micropulse. You have to treat the whole area of thickening and be very dense. Don't go above 10% duty cycle. You need to be patient. A perfectly performed laser takes between 6 to 12 weeks to show its effect. And we believe that yellow subthreshold laser has a more beneficial effect than half dose PDT for CSR. It's certainly very cost effective and should not only be considered in rescue situations. So in conclusion, please come to Malaysia. We're going to have a special workshop, instruction course, and several seminars on this modality in February next year. Thank you very much.
Thanks, Ken. It was fantastic presentation. Anand, you are muted.
Sure. Go ahead, Jim.
Yeah, so very nice and lucid presentation and a great foundation for the rest of the talks. I think something very important you brought in was the term called subthreshold. I think there have been a lot of, I can't find a better word, confusion about this term. I think what is more important for all of us who are using this technology is to understand what is the difference between subthreshold, subliminal, sublethal. These are some very important terms, and I think overall, I prefer sometimes to call this as a retinal restorative therapy, where you are not actually destructing any retinal tissue, but because subthreshold laser helps to prevent the destruction, that's why we should call it as a retinal restorative therapy. But with this, I would say, does anybody has any questions for Ken? Any comments on the basics of subthreshold?
Hey, can I ask a question?
Please.
Yeah. So, Ken, you said you titrate the power. So when you titrate the power, you use the power in a micropulse mode or in a full
in micropulse mode. So I use at 5% duty cycle. I choose an area outside the macula. Normally, if it's an Asian eye, I would start at about 600 to 700 milliwatts. If I see a mild reaction, then I know I'm there. I reduce it by half. So on the laser machine I just press the button 50% and immediately reduces the power by 50%. So it's normally between 300 to 450 milliwatts at the subthreshold power at 5% duty cycle that I use to treat the thickened areas.
One more question. When you do this test one, it's a single spot or it's again a gray?
Single spot. Single spot, yeah.
Lita, you had some comment?
Yeah, I wanted to add that the reason why yellow wavelength is better than 810 is that because it allows titration under the micropulse mode. If you use the 810, it's really hard to get the burns to be seen. So that's why with the 810, you probably, if you wanted to do titration, then you probably had to do it under conventional continuous wavelength. And that's where sometimes you get into problems because you forget to turn the laser back onto micropulse, and then you end up doing a continuous wave treatment. So that is one of the advantages of using the yellow wavelength.
I have a question to Ken. Is there time for that?
Yeah, please go ahead.
Ken, just one question, because all these topics are going to be covered in the course of the seminar, but I just thought I'll ask you now, in diabetic macular edema, do you treat all patients with micropulse? That is, even after the anti-VEGF as a routine? Do you practice micropulse as an add-on therapy in all cases?
Yeah, it's a discussion with the patient. Those who are extrafoveal, who good 6/6 vision, I think they're perfect candidates for laser. You don't have to start injecting them early.
Yeah, that's okay. But I'm talking about patients with center involving DME.
Yeah, I would still give anti-VEGF.
Yeah, after the anti-VEGF, do you routinely also give micropulse in all your cases once your edema is reduced, or you pick and choose patients?
I pick and choose. It depends on the residual thickness and how they're doing. I do use Ozurdex quite a lot as well, because I find that that is also good therapy. So not all DME patients get it, but again, it's a question of discussing the choice with the patient. And a lot of patients actually are needle phobic and also find it a lot of hassle to come for regular injections. So if you have that option of laser that is helpful, I think they would also like to consider that.
Victor, can you just add on to that? I mean, do you have anything to say?
Yeah, so I think that like what Ken said, when to use it, who to use it is, I don't think that we have universal agreement. And whether that we consider doing it for every patient is always a discussion that we seldomly do anything for every patient, right? So I think that's why physicians make decision. And even that, like Ken mentioned that he tend to use the anti-VEGF first before the laser. And I actually tend to do the laser, first and then before the injection. Or even on the same day, we do the injection, when we do the laser and then the injection. The reason is like there's a pros and cons for that. I think Ken is right that if you do the injection first, then you reduce the edema, and then you can do the laser more precisely. On the other hand, that laser do take a little bit more time to work, so you have a kind of temporal sequence. So if you think that you can manage to do the laser, if the edema is not too much. Now again, I appreciate that in different country the presentation is different. And in the UK, where I used to practice, that because of the screening program, they tend to come in a bit earlier, even with century involved. So it might be there is a difference that I were able to do the laser when there was still some edema, and then it helps because then the laser start to work, while the injection is also working. So I think that's a pros and cons that depending on the patient.
Yeah. So one last question by Raja. Raja, you had something to say?
Yeah, so I'm mindful of the time too, but very nice opening actually from Ken. A lot of questions and great presentation. I still would like to, over the course of these discussions, we need more level 1 evidence for different diseases. Different diseases have different mechanism of pathophysiology. Some are at the level of RP choriocapillaris, some are, let's say, microaneurysms and diabetic macular edema, where I still believe that we may have to, one laser or one parameter may not be able to solve everything. But I like the basis with which Ken started, that intravitreal injections, chronic and repeated, how long can we sustain this kind of injections? It's a strong basis to work out these. But I still believe that for each disease, we may have to come up with different protocols. I think Jay will be talking about it. I hope he will be talking about it later. But there are questions about which laser, what parameters for different diseases.
Sure. So